My name is my name is Professor Mary Viktorovich, and I'm the acting director of the Dadala Institute while James Orbinski is away. So today I'm delighted to host Professor Charity Oga-Omenka, who will lead today's seminar entitled Advancing Patient-Centered Access to Tuberculosis Healthcare in Low and Middle Income Countries. Before we begin, I'd like to begin by acknowledging the Indigenous land that we're on. And as this is a hybrid event and some of you will be on different territories, please take a moment to give thanks and respect to the land which you're currently living and working on. So here today on the York University campus in Toronto, we're situated on the traditional territorial area known as Tikaronto, and we acknowledge its current treaty holders, the Mississaugas of the Credit First Nation. We acknowledge this as the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. This territory is subject of the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. So at this point, I'll hand it over to you, Amrita, to introduce Charity to us.
Thanks, Mary, and welcome, Charity. I'm really so delighted to introduce and welcome Dr. Charity Oga-Omenka for our seminar today. Charity is assistant professor at the School of Public Health at the University of Waterloo, and her work focuses on global public health, healthcare access, and health services research, particularly for infectious diseases that we both love and hate, like tuberculosis, HIV, and COVID, the social determinants of health, and the intersections between the different layers of health inequities. Dr. Oga-Omenka is invested in using and developing rather transformative conceptual frameworks and methods to address inequalities, and especially the underutilization of evidence-based innovations in resource-limited settings, as well as marginalized communities. She's a mixed methodologist, very well published, trained at highly reputed institutions in Nigeria, South Africa, and Canada, and just all around a brilliant researcher. I've had the privilege to have known and worked with Charity and taught with her on several occasions, and she has become a good friend. She is a rising star, currently one of 30 leaders to have received the Women Lift Fellowship in Global Health that's sponsored by the Gates Foundation. So without further ado, Charity, I'm really excited to hear you speak. Welcome to the Dadley Institute. The floor is yours.
Thank you so much, Amrita, for that warm welcome. And I would like to thank the Dadali Institute for Global Health for inviting me today, and for everyone for braving the cold, and for everyone also joining online. I think I'll just jump right in. So as an overview, right, I'll be discussing the global TB burden and just focus a little bit on the three countries where I've done some work, and also talk about the principles of patient-centered care and how to center that. What are some of the frameworks that we have used in our own work and we've seen other authors use as well. Then I'll talk a bit about the methodological review that we're doing, just trying to understand the patient journeys to care, to TB care, and then talk about some of the mixed methods analysis that we have done from our own data collection in the three countries. So as an overview, TB is the deadliest infectious disease after COVID. Every year, between 10 to 11.5 million people get infected. And probably 3 to 7.5 million of those are missed by the healthcare systems, right? So in 2022, 10.6 million people contracted TB, 1.3 million died. And out of this, we had the highest ever notifications in the history of WHO reporting TB stats. We had 7.5 million people that were diagnosed out of the 10.6. Even though this is the highest ever we've ever recorded, it still leaves 3 million people that have been missed by the healthcare system. So generally in the three countries I've worked, which is India, Indonesia, and Nigeria, doing TB research, data showed that during the pandemic, there was very, very significant impact of COVID on notifications for TB, which is where most of my work is focused on, and I'll explain why in a little bit. So India and Indonesia particularly had very dramatic falls in notification in 2020. and are beginning to recover from the impact of the pandemic. However, Nigeria was a little bit different out of the most of the high burden countries because Nigeria made progress, a lot of progress, significant progress anyway, during the pandemic. So 10 countries had the largest gaps in notification in 2022. And out of those 10 countries, India, Indonesia, and Nigeria were prominent amongst those. So when you look at the 30 high burden TB countries globally and the coverage of treatment, or which is also the notification rate, what proportion of TB patients that have been estimated incidents were notified? Because the assumption is that they are notified, they are placed on treatment. So what proportion of these are covered? This is called the treatment coverage indicator, right? So the treatment coverage indicator for 30 high burden TB countries. For the 3 countries that I'm interested in, we see India just recovering from the pandemic at 80% in 2022 compared to 2019, where they had 77%. The incidence in 2022 was 2.8 million in India. In Indonesia, incidence is 1 million, and they are right back to where they were before the pandemic at 67%. Nigeria has an incidence rate of about 500,000, and they have doubled the coverage that they had in 2019 at 59%. Now, another thing that is interesting about these high burden countries is that a lot of them have a significant private sector healthcare service, right? So the 3 countries that we're interested in, Nigeria, Indonesia, and India, have significant, very prominent private healthcare systems where 65 to 85% of initial healthcare seeking starts with them. They don't happen in the public sector. We also see that for 2022, these 3 countries did not have significant reporting from the public, so from the private sector, right? Between 25 to 35%. So thinking back to the proportion of patients that seek care first in the private sector, which is between 65 to 85%, the private sector is reporting between 25 to 35%. So there's a gap. We imagine or we assume that private sector should report much more than what they're reporting. But there's progress because if you look at the blue lines on the chart on the right-hand side, the private sector reporting has taken off significantly in these countries. But even with that, we still have a lot of gap. That brings us to, these stats highlight a problem that we have in TB care, which is that patients that need the care that we have are not accessing treatment. So what are some of the problems that are preventing patients from accessing the right treatment? So dimensions of poor access and quality of TB care. The Lancet Commission on TB that Amrita is part of has summarized the work of several researchers and have just given us this beautiful infographic summarizing some of the problems that we have that patients have in accessing quality TB care. So many of the problems are around diagnostic delays, treatment delays. Patients, like half of drug-susceptible TB patients and 1/5 of drug-resistant TB patients are diagnosed, right? So there's a huge gap, and the patients are also lost to follow-up. And some of the issues that the patients have is the cost. Sometimes even where the country is providing the care free, like some of the studies we have, the care is supposedly provided free, but patients have to transport to get there. Sometimes they don't have the right information about where these services are. There's not enough linkage between the private and the public sector. There are a host of issues, right? So all of these issues are broken down into like population, the governance issues, platform issues, workforce issues, and tools that we're using in TB. So there are lots of issues that have continued to plague TB care over the years, which is why we still have in 2023, 3 million people being missed by the healthcare system. Now, the Piper Institute and Harvard Medical School has recommended 8 principles of patient-centered care. This includes respect for patients' preferences, coordination and integration of care, information and education, physical comfort, emotional support, involvement of family and friends, continuity and transition, and access to care. And under access to care, you think of issues like, availability of facilities, providers, appointments, transportation, quality, and all of that. So there's a lot in this chart that speak to what we call patient-centered care. Now, so what is access? The access can be defined as a degree to which individuals or groups obtain needed services from the medical care system. I like the way the Institute of Medicine has defined this. They've added the equity dimension, and that equity dimension highlights the fact that patients should be able to secure adequate level of care for themselves without excessive burden. And that brings us to catastrophic spending on TB, which is still very, very high from the last report. So there are several dimensions that different researchers have brought in understanding access to care, right? So there's the population dimension, predisposing factors, enabling factors, need factors, utilization factors. And then there's issues within the health systems as well, policies, resources, organization, financial and geographic accessibility. Then we have availability, affordability, acceptability, appropriateness. A lot of us that have been working in access, we are very familiar with these terms. So a lot of times when we talk about improving access, for example, in Canadian healthcare system, what comes to our mind is getting the supply to match demand. And at the base of it, TB care still has a lot of gaps in funding for what needs to be done. So there's a gap in funding, what the WHO estimates to be needed to take care or to meet the SDG goals or the MTD goals is one amount. We're still falling short of that. But a lot of times in the countries that we've worked in, the resources are there, but the patients are not. So this is kind of like a different kind of scenario or a different kind of access problem where some services are available, but the patients are not even accessing the available resources. And you can begin to think about how this is tragic in a way, because all of the advances that we've made in biomedical care, the diagnostics, the medications, all of the work that brilliant researchers all over the world are doing to improve TB care is not reaching a lot of the patients that need it, 30% of the patients that need it, sometimes 70% of the patients that need it do not access it. And that's really, really tragic. And what does this mean for the healthcare system? The immediate logistical problems are like drugs are expiring, lab reagents are expiring. But beyond that, there's community infection. There is patients, finally getting to healthcare systems when they're so ill that it takes more specialist care to take care of them. There's increased risk of death because now the disease has really ravaged their bodies. And patients talk about that when we interview them. Now, this is a lot of frameworks right here, right? I'm just gonna just say breathe and just let me walk you through some of them. I'm not going to be able to exhaustively deal with all of the frameworks that are here, but these are some of the patient-centered access frameworks that I've been exposed to in my work. A lot of them I've also used, and I'll talk about how we've applied them. The first one is the access to personal healthcare service. This is the one by IOM. So it talks about barriers to care. There are the personal barriers, the structural barriers, the financial barriers, and the use of service utilization. And then it has the mediators, like the appropriateness of care, adherence, quality and all of that is within the mediators. And then what are the outcomes, the health status? Did the patient get a cure? Was the patient satisfied with the service? That's the first framework. There's one very popular patient-centered access framework, the one by Levesque et al. I've used this extensively in my work. And this says that, that there are some qualities within the healthcare system that need to match qualities within the individual or groups of population for access to happen. So these are the paired access dimensions. The first one is approachability. The healthcare system needs to be approachable. And beyond being approachable, the individual or the population needs to be able to perceive that the healthcare system is there and is approachable, right? So that's the first third dimension. The second part is the acceptability of the services. So the healthcare system needs to deliver services that are acceptable for the population that they are working with, right? So this talks about a lot of contextual issues, depending on cultural issues or whatever, like whatever service we're delivering needs to be acceptable to the people that we are targeting this with our services. And then the population on their own hand need to be able to seek out this. So that's the third dimension, that's acceptability and ability to seek. The third dimension is the availability. The services need to be there, there needs to be adequate coverage. And then on the patient side, the patient has to have the ability to reach the available services. So that's the third one. Then we have the affordability and ability to pay, and we have the appropriateness and the ability to engage. Now, the third one is the one by Subaraman. I've also used this quite extensively in my work, which says, let's take the incidence of TB as a number, right? Out of the number of people that are estimated to have TB in a particular population, how many of these are even getting tested? So that's the first proportion, right? The first step. Out of those that are tested, how many of them are diagnosed, right? And then out of those that are diagnosed, how many of them are treated? Out of those that are treated, how many of them complete treatment? If you look at this cascade of care and you look at the numbers, sometimes your jaw drops because of how shocking the numbers just is, like falling off the cliff, right? So the incidence, at some point at the beginning of my research, I started to doubt the WHO incidence rate. I was like, there's no way this number of people really have TB. How come we can't find them? How many of them, just saying 10 million people, for example, are infected by TB, and then by the time we come to the next stats, which is testing, you see maybe 5 million were tested. Between 10 and 5, that's a huge shocking number of that were missed, right? And then between testing, which you would think that it's a simple step, I went and gave my blood or my sputum for testing or whatever, I should get the result. But that simple step between testing and diagnosis, another shocking drop off, right? So I've used this extensively, and several researchers have used it. Publications are there just showing different countries, just the shocking drop off of numbers across the cascade of care. So that's the third framework. The other one is the patient pathways that it's sort of developed by two researchers, Hansen and Chin. But what they did is trying to see how the supply matches the demand. So saying, for example, we estimate this number of people in this population have TB. What are the services that are available to them? How many testing sites do we have? How many diagnosis sites do we have? How many treatment sites do we have? That's the patient pathways. And then we have the delays. Several authors have contributed to this. In fact, when you talk about patients' journeys or patients' experiences in TB care, the literature is filled with delays because most people focus on delays. And the delays are from the time the patient noticed the symptoms, how long did it take them to go to the healthcare facility? From the time they visited the first healthcare facility, how long did it take the provider to ask for a test? From the time the provider asked for the test, how long did it take them to get the test, and on like that. So those delays are broken into patient delays, then are broken into health system delays. Within the health system delays, we have the diagnostic delay as one block, and we have the treatment delay as a second block. What we've seen is that diagnostic delays are among the biggest delays that patients face. And patient delays are also there because sometimes patients don't even have transport. They don't even know where to go, right? So patient delays, diagnostic delays are the biggest problems that we have in TB care. Treatment delays is it's not good, right? Because any kind of delay, once you found the patient, you expect that they should be placed on treatment. So treatment delays are not good, but we find that the proportion of treatment delays in TB is not as high as the other delays. Then the final piece, which is the health scheme journey analysis, I'll probably spend a bit more time on this because this is directly from our work over the last few years, which is more saying, patients' experiences from the time they recognize their symptom and the time that they have the outcome of interest. So this outcome of interest could be diagnosis, it could be treatment, right? So between the time they had their first symptom, how many providers did they see, right? Number of providers, timing of provider encounters or visits, the type of providers that they saw, which sector were these providers, and then at what point did they get appropriate care. Now, so this is how we've applied this in our work. When we talk about the cascade of care, what I was explaining earlier, when I did the cascade of care analysis for Nigeria between 2013 and 2017, thankfully, this has improved dramatically in the last 3 years since I did this analysis. But at the time I did it, between the incidents, like 100%, let's take what the stats for Nigeria, 500,000, right? Just 20% of those are tested. Right, and then out of the 20% that test, not out of the total proportion of those that eventually get diagnosed, out of the 100% is 5%. And how many are treated? 3.2%. This was absolutely shocking for me when I did the analysis. I was like, there is no way. Just 3% of patients are getting treated for drug-resistant TB. So I sort of did like an analysis trying to see at what point in the cascade, what were the factors, right, that influenced each of these shocking stats that I saw in the data. And I broke them down by individual level factors, interpersonal influences, just like the Anderson framework that I mentioned earlier, and then the health system factors, right? So, and then I broke them across each of the cascade steps, right? So, for example, the biggest gaps that we have is around testing and diagnosis in TB. So what we found, for example, under testing was that patients were not aware of individual factors. Patients are influenced by a recommendation from a trusted person, interpersonal factors. Health system factors, low index of suspicion. Then when we come to diagnosis, the reason why patients were not getting diagnosed, they were not returning to the facility to pick up their medication, and the facilities sometimes do not have the right way to track these patients. So patients not returning, so lost to follow up, cost of transportation, inpatients, testing delays. So the patient is waiting and waiting, and then they get tired, inpatient, and then they go away. The personal factor, the community misconception. Oh no, you don't have TB. It's something else that is, some spirits are worrying you, or your neighbor is after you, kind of thing. Community misconception. And then you have the health system factors as well, logistics around labs and all that. I'll just stop there because of time, but these were some of the factors that I found using qualitative research. So the first part, the cascade analysis, was quantitative. And then the second part of the barriers and facilitators was, I used qualitative research for that. I also use the third dimension, the Levesque framework, where those 5 third dimensions. So for approachability and ability to perceive, I found that when the facility did active case finding or referred patients, then that really improved the approachability of the health system. And then when there was a higher index of suspicion, then that also improved the approachability of the system, right? So then on the patient side, we found that when the patients are aware, maybe someone told them, go to that facility, they are testing people that cough, they may be able to solve your problem. That would really, really improve the approachability of the system and the ability to perceive. On acceptability and ability to seek, there was this issue with distrust. Patients were distrustful of public facilities and the attitude of healthcare workers. And then on the ability to seek, patients sometimes were limited in their autonomy to make health decisions by themselves. This mostly affected women and affected children because they needed, in the case of women, we found some women that needed to get permission from their husbands to be able to access care, and we saw some children where maybe the mother or the father did not believe in orthodox medicine, they preferred to take them to a traditional healer. So those autonomy issues, where the patient can make a decision for themselves without, the consent of someone else, really impacted their ability to seek. Then availability and ability to reach, we have all of these factors. So I just broke it down just to show you that, this is how I've applied some of this in my research, just to understand the barriers that patients are facing. And then I have some sample quotes here. For example, under individual factors, there was a patient that said, oh, I went around for 9 months before coming here, to the point where they were finally diagnosed. I've gone to prayer houses, I've done everything possible. I went to every possible place. They mentioned in that interview, going to prayer houses, going to traditional healers, going to several private vendors, self-medicating within the 9 months, right? Before they finally got diagnosed. Then interpersonal factors, there's this case that I keep talking about all the time, just because of how much it impacted me at the time. So we had the National TB program gave us the registers of people that were not diagnosed. And so we're trying to trace them just to get like the negative case that we could interview to find out why were they not accessing treatment. And so in flipping through the pages, making calls, we contacted this woman in her 20s, and she said she wanted to start treatment. And so we had a follow-up call with her, trying to link her with the healthcare system. And just a couple of minutes into the interview, some commotion on her end, you're hearing a lot of noise, and then a male voice shouting angrily into the phone, do not call my daughter again. I believe she's healed. We've taken her to the prayer house. Never, ever call her again. And then the phone goes up, and we try to call, and apparently they had blocked our number and we couldn't reach the patient again. This was shocking to me that someone wanted, an adult wanted to access care, and yet the family influences were preventing them. Another shocking part of this case for me, and why it continues to haunt me, was that this is drug-resistant TB. The percentage of patients that die from it without treatment is more than half, maybe 70% of patients. So this is a life-threatening illness. That's one. Number two, of course, as the research team flagged it to the national TB program. But the problem with the national TB program was we cannot go against the family wishes, right? If we take them away from their family, are we going to absorb them into society and find them a new home? There's just a lot of factors that prevents healthcare systems from intervening, or, you can't go against the family, right? So this was one case that stayed with me for a very long time. Then healthcare systems, where attitudes of healthcare workers, patients complained about that. These are some examples from the qualitative research. Now, in the last 2 years, the work that we've been doing is sort of trying to understand patient journeys, right? Because when we look at literature, when you do a quick literature review, it seems that a lot of TB literature focuses on delays. So saying, for example, Charity started coughing in March 2023, and she waited to September 2023 to go to the healthcare system or to be diagnosed, paints the picture that Charity was sleeping every day, not doing anything, just chilling, and then one day woke up 9 months later and went to the facility. This is not at all reflective of what we are seeing with patients. Within the 9 months before they are diagnosed, patients are going everywhere. It's just, so for example, and so another point that I'll say, at the very beginning of TB, patients don't usually realize that it's TB, right? No one wakes up with a cough and say, oh, I'm going to destroy the rest of my day and wait in the emergency for 9 hours because I have a cough. You say, no, maybe I didn't sleep well. Let me take tea. Let me ask my mom, what does she take when she's not feeling well? Maybe it's the flu. Let me ask my mother-in-law. That's what people usually do. But this usually lasts, I don't know, 1 month at the most. By 1 month time, it becomes really critical and the patient just starts looking for care. And so what we've seen is that patients are really searching for care. And it's almost like TB services are difficult, shrouded in mystery for a lot of patients. They just cannot penetrate this system that we have created. They don't know where the services are. And so patients are just going, they go to provider one, they go to provider two, and they're just scrambling, using all their resources. And I want us to just imagine, for each single time the patient meets a healthcare facility provider, imagine what they had to go through to get there. They had to take permission from work if they have a boss, or just close their stores. They have to find childcare if they are parents. They have to lose income for that day. They have to enter transportation. They pay for it. They have to wait in the healthcare system for 9 hours or whatever time, eat there if they have the appetite for it. So their whole day is destroyed. So imagine 9 months of this kind of injury. That's why catastrophic costs for TB are really high, right? So because of that, I wanted to understand which other way can we understand patient journeys beyond just saying delays, that the patient waited 3 months, which is what the literature is suffused to. So what we did is that we set so many databases out of like 22,000 papers that we initially got. We retained 65 of them. And so in that initial, so we did a preliminary literature research review. This process has taken us 3 years. We started in 2021. And we're only about to get the first draft ready, because several times we'll start and then we'll restart and then we'll think, and then so it was like an iterative process. But what we found is that several variables, depending on the method that you're using, if you're using quantitative, of course, it's variables. If you're using qualitative, then it's factors or themes or whatever. Several themes help us, or factors help us to understand patient care journeys, right? So the first is the number of provider encounters. I find this to be much more telling of the problem that patients are having than just saying delays. Sal would prefer number of provider encounters. So it's like the number of visits to a healthcare provider it took for the patient to go from initial healthcare seeking for their symptoms until they were diagnosed. So number of provider encounters to diagnosis. So for each of these encounters, what is the type of provider that they saw? For the first encounter, who was the provider they saw? In which sector was the provider? And then the proportion of patients. So if you're doing analysis on the number of patients, what proportion got diagnosed at the first visit, what proportion got diagnosed at the second visit, and on like that. Then you repeat that for treatment, the step between diagnosis and treatment. And then overall, you also want to see time to diagnosis from the first you want to see time to healthcare seeking, right? From initial symptom recognition to when they started seeking care. That's the first one when you're looking at times or delays. And then from there, you want to look at between that initial healthcare facility visit, how long did it take them to be diagnosed? How long did it take them to be treated? And then you look at some of the risk factors. Now, what we saw is that it didn't matter the method that you use. All of these methods would help you to get this type of variables or these factors. Qualitative research, you can use that. The only part of qualitative research sometimes is that the proportion of patients per encounter, because qualitative research is not designed to capture numbers and all that. But I've seen researchers do proportion of patients even with qualitative research. But what we found is that if you do cohort study, you do cross-sectional, you do mixed methods, you do qualitative research, you're able to find all of these variables because we found it in the papers that we searched. The only one is the Hansen and Chin model, the patient pathway analysis, just because it focuses on the alignment of healthcare systems with the coverage of healthcare systems with the demand. It does not really look at type of facility, the actual patient journey. So that's the only that's the only type of study that's not well suited to expose all of these variables that we identified. Then we also saw that different researchers portrayed these journeys in different ways. There was no particular preference, but we found that tables and flowcharts were the most commonly used by researchers. Now, I'll quickly take us through the COVID study. The COVID study is the impact of COVID, the effect. Let me go back a little bit. COVID effect on TB, the COVID study that we did in the last 3 years. It was done in Nigeria, like I said, Indonesia and India. So a very large study, and it involved 116 interviews total that we collected, about 5,000 surveys, but they were not all patient journey or pathway analysis. Some were just provider surveys about the impact of COVID, facility surveys or mapping, standardized patient studies, and then policymaker interviews. But within the patient pathway analysis, we collected close to 1,000 surveys. Now, so there are some differences in the countries, right? The most telling or the most significant difference is that for Indonesia, we did this study in Bandung in Indonesia. We had access to pre-COVID data set that looked at the same variables. So we're able to compare pre and post-COVID. We didn't have the same data in the other countries. Then in each of the other countries, we did 2 cities, but in Indonesia, we did 1 city. And so some of the variables differed a little bit, but the most significant difference in how we collected the data at the time, because we didn't know enough at the time, right? Because this was also a learning process for us, was that the Indonesia data collectors focused on visits, while the other countries focused on encounters. It may not look like a big deal. At that time, we didn't think that it was a big deal, but later on, we'll find that it was a make or break, more or less, right? Because when you say number of encounters, if a patient went to provider A 5 times, they'll count it as 1. But each of those encounters involve them taking time off, like I explained earlier. But the other countries were measuring encounters. So just saying, oh, the patient saw 5 different providers, that's still a lot. It still gives us a lot of information. But with each provider, how many times did they have to go back home, sleep, and come back the next day? So this was the difference with Indonesia data. So when I'm talking about the stats, keep that at the back of your mind, that's why some of the Indonesian numbers are higher than the other countries. So what we found is that clients in Lagos, Nigeria had the least number of encounters, followed by Kano, Nigeria, followed by Patna and Mumbai. Then clients in Bandung had the highest number of encounters because they were counting visits instead of encounters, like I said. Then when you look at health seeking and treatment delays in the 5 cities, again, Indonesia seems to have the highest numbers because of the way they counted again. But we saw that healthcare seeking delays were least in Patna, in India overall, Patna and Mumbai, followed by Lagos, and then Indonesia had very long health seeking delays. But once the patient got to the facility, Indonesia now had the least treatment delays, followed by Mumbai, then Lagos, then Kano, and then Patna. So there are several ways that we try to capture the patient journeys in our own research. The first way is the Sankey chart. Now, looking at I'm using an example from Patna, which is in India. When you use the Sankey chart, what we have found as an advantage with the Sankey chart is that it tells you the number of individuals at each step of the journey, what proportion are being diagnosed or moving to another facility, right? So you're able to see the flow of the patient between different types of providers. So you can see, for example, that, at the first encounter, 29% were diagnosed at the recruitment facility, but the rest, which is like 70%, had another provider. And then with that second provider, about 40% of the total numbers, or 62% of those that got to the second stage were diagnosed at that second stage. They didn't find another provider. So like that, the Sankey chart gives you information on how patients are moving, what proportion are being diagnosed at each step, which helps to inform our framework that we have just developed. Now for Indonesia, looking at the visits, when you're using Sankey chart, it gets very clunky. That's the initial chart, this one. It gets very clunky when you have more than like 5 encounters of visits, because then the chart becomes really unmanageable. You can't even interpret anything. So for those kind of charts, we have like the matrix chart that helps, which is kind of like a stacked bar chart, and helps us to visualize where our patients going. So on this chart, we're able to compare pre-COVID with during COVID. And you can just see some differences just glancing at it, right? So each line, each row represents one patient. And then you see where the patients went until they got diagnosed. For example, in the during COVID chart, you can see that the end parts are more like greens and browns, right? Showing that patients are ending more in the private sector than compared to the pre-COVID sample. Also in the during COVID sample, you see a lot more of the pinks. And these pinks are like the informal providers. So quickly you're able to see, before COVID and during COVID, patients seem to be using more informal providers during COVID. So this kind of chart is also very helpful. Then we have another kind of chart that we use, also the matrix chart, and it's also another type of stacked bar chart that helps to visualize, shorter journeys, right? That's similar to the one we just saw. So even though that's, the first chart looked at like a lot of visits before diagnosis, even when there are fewer visits, it's also good to visualize it using the same type of chart. So here you can see like a lot of patients getting diagnosed at the first step and the second step, and very few getting to the third step or fourth step. In fact, you can see just comparing Lagos and Kano, for example, that a lot more patients got diagnosed by the third encounter compared to Kano that had more patients at the fourth encounter. Just looking at this chart, without me saying anything, you're able to see from the colors that, oh, this is what's happening. So this is a nice way to visualize patient journeys. Then we also have something called the missed encounter chart. It's very similar to the matrix chart, but it's more or less like saying at what points were they diagnosed, right? And then seeing which proportion falls above the curve and which proportion or what type of providers fall below the curve. So the curve is the point of diagnosis. So you can see, for example, in Indonesia before COVID, that a lot of, comparing pre and during COVID, a lot more of reds happening during COVID, which is we saw that with the initial chart. So this is sort of saying, if you want to design an intervention, where do we target? It seems like informal providers are becoming more prominent during COVID. So we did the same for India, not to bore you because time is going, but then I come to what have we learned about access by doing all of these studies? We've learned that, it's cross-cutting. Patient-centered access is cross-cutting. There's issues of social justice and equity, issues of disease and context issues. There's data quality, there are cultural norms, and then there's just the donor priority, right? What do they want to even fund? And then the political will. Then we have on the patient side, like we've highlighted, information about the services, cost of services, health-seeking behavior, beliefs, cultural norms, direct and indirect costs. Within the healthcare system, how much financing do they have, what's the coverage, the waiting times, and the quality of care, provider knowledge, number of encounters, pattern of provider, and missed opportunities. So I want to say that TB is a disease that preys on marginalized people. It's a disease of poverty. And it preys on people that, have maybe lower income or whatever. So what we're seeing is that a lot of patients that need these services are not accessing them. Makes us wonder, is it the patients that are not accessible, or is it the health systems that are not accessible? This is the question that we need to ask ourselves, right? Are the patients hard to reach, or is it our services that are hard to reach? I mean, if someone has to take 20 encounters to get diagnosed, then you kind of wonder if it's that person that is hard to reach, or is the healthcare system that is hard to reach. And so I'll end here by thanking you all again, but also thanking the team and the universities and the countries and the national TV programs that have supported this work. We have McGill University and International TV Center. We have Georgetown University in the US. We have ICED team in India. We have Universitas Padjadjaran in Indonesia, Shops Plus in Nigeria, University of Waterloo team. The three countries, their national TV programs are really wonderful in supporting us for this work. And then the Gates Foundation for funding us. Thank you.
Thank you so much, Charity, for that really fascinating talk and looking at all those barriers and bottlenecks. I guess maybe I'll start with a question. And I guess something that came to mind was you noted that TB care was often free at the point of delivery, but are they in healthcare systems that aren't necessarily free? So would the sort of privatization overall be a barrier?
That's a very good question. Thank you for asking that. So yeah, what the funders and the governments of these countries have done largely is that when resources for TB care come in, right, they provide they take, they sort of have like a map and we say, okay, we'll put it here, we'll put it there. So usually they are like in TB dot centers called, this was the older model of, doing TB in many countries where patients have to turn up, show themselves, show their card, and then they are given medication. So a lot of these services were going there, and most of them are in the public sector. Now, patients are going to the private sectors, and not enough has been done by most of these countries to make sure that these services are also in the private sector where patients are going. So where the services are located within the public sector, it's free. The program supports patients even paying for their cards. There's no consultation. There's nothing. Once you can be identified as having TB, all your fees are waived because the program has supported that facility. However, the location of the facility now becomes a problem. Patients are going here, and then the services are right here. So all the services are in the public sector, but patients are going to the private sector. This is a problem that we have found, at least in the three countries that we have worked in. So when they go to the private sector, of course, the private sector provider wants to maximize his profits, right? So he's asking patients for different tests, he's misdiagnosing patients, he's giving them all kinds of things and charging them for each of them. Well, so the patients are not able to find the right place where they can get the free services, which is why I said it was almost like a cult kind of thing around TB services.
Right. So they almost have to have a hunch that it might be TB and to go to the right place as opposed to, okay. And that's a challenge overall. Yeah. Okay, thank you. Godfrey.
Yeah, thank you for that presentation. Quite interesting. I have a few questions, if you don't mind. One, I looked at the various frameworks you had been using, and I wondered if you had considered the Donabedian framework. It has also been used within healthcare systems, and it gives you the structure, the process, and the outcome. And I was thinking maybe it could further expand your work or give you more insights into what you are exploring with TB and its access. And number two, you talked about patient-centered access, and I was wondering, though it is qualitative, if you had looked at differences by sex, gender, socioeconomic status, how is this playing out from the data you've been able to draw out, or from the various articles you have been reviewing, and said in terms of hard to reach patients, I wondered, you were talking about whether it was the patients that were having difficulty getting there, or the challenges were within the healthcare system. And so, is there a matter of quality of care? And if that is the case, have you assessed that? Because that could also give you room to consider what measures could be put in place at the organizational level to mitigate some of the challenges these vulnerable populations already have coming to the place. Yeah.
Thank you for these questions, right? So I'll start with the first one. So in terms of, oh, I just forgot the first one. I'm trying to arrange it in my head. Can you remind me the first one again?
Yes, I was asking, you talked about various frameworks, about
exactly.
4 or 5.
Thank you. So the framework that you mentioned, I haven't seen it, but I would love to see it and see how we can apply it and, to our discussions of some of, what we have done. So I wonder if you're able to share it.
Yeah, I'll share it.
Okay. And so for the second one, for the social demographic characteristics and how it impacts on access, we have used quantitative data as well. So we have seen differences, in gender, in income, in geographical location. But this is not, I would say it's not definite. It depends on the context. In some places, men have a harder time accessing care. And biologically, men have more TB than women, right? So in some places, that still shows in the numbers that, okay, when you break it down without, controlling for confounders or whatever, it looks like, men, the proportion of men not accessing treatment are more. But when you also, do qualitative research and you try to see, control for that, and you try to do some of this analysis, we find that women, sometimes because of the burden of healthcare, health caring, caretaker role, are impacted negatively by TB. And then some of the cultural norms that I mentioned earlier also prevents women and children more. But this is not a significant finding in most of the data that I found. I have specifically questioned some of the data that I've analyzed to see whether it's showing up as a significant proportion. But I think in just 1 or 2 locations you may see that happening, maybe in one state or the other, but it's not a huge number. I think the major social demographic characteristics that impact on access to care from our data seems to be geographical location, rural versus urban. That's one. There's also the educational level, right? So the higher the education, the more informed, or the more the individual is able to persist until they locate the right services. So the lower educational status seems to be a negative factor impacting on access. I think those are the 2 major ones that I've seen in our data, just showing up repeatedly: geographical location, educational factor. We even try to see whether symptoms, the first symptom that prompted healthcare seeking, is a factor. And we found that it's a factor for some, like in terms of the number of, when we tested, like, for example, number of providers seen before diagnosis, and we test that against, maybe the social demographic characteristics or the symptoms. We're finding that when patients have cough, they end up seeing more providers. If cough is the one that is prompting you to go to the healthcare system, they seem to take it for granted. So they go to the neighborhood pharmacy first, then they go to the pattern medicine vendor, then they go to the private clinic, come back to the pharmacy, then go back to the clinic, then come back. So cough was something that was minimized and just taken for granted, which led to seeing more and more providers. But if, for example, the patient had coughing out blood, then it shortened their journey because it was like, oh, whoa, I'm seeing blood, I need to get to the facility faster. So those are the things that we saw that were like risk factors or like, significant. Then for the last question, which I hope I'm remembering, sorry, remind me again, I'm sorry.
Yes, I was talking about the quality of care, if you've examined that.
Yeah, exactly. So we did, as part of this study, we did the SP studies, which is the standardized patient study. That one was focused more on alignment to guidelines, which is not the focus of this study, but just generally to say that sub study looked at, in each location, what what proportion of providers follow the guidelines in terms of, okay, if a patient comes with the classical symptoms of TB, which is like, cough for 2 weeks, with like losing weight and all of that, when they appear at the healthcare facility, what proportion of providers test them for TB right away, and what proportion send them away to go? So we've done those kind of studies to compare between the private sector and the public sector. And of course, we find that in the private sector, patients have lower index of suspicion, and they're not as regulated as in the public sector, which is why the WHO TB private sector engagement group, working group, are working very closely and trying to get, countries to engage the private sector more. You think of the kind of incentives so that these providers that are running the business can at least have a reason to send patients to the right place. Or even some have advocated for taking the services to the private providers and engaging them, because private providers can also be incentivized by other things beyond profits, like just being professionally recognized for the work that they do, being plugged into the national TB program. These are things that private providers, like all of us professionally, we want to be part of something bigger than our own practice, right? So when you put private providers into that kind of system, where the the national TB program recognizes their efforts and make them a center for diagnosis or whatever, we also find that private providers are referring patients even without monetary incentives. So the WHO working group on this is really making a push to get countries, and countries have done a lot of work. Some of the data I presented was like in 2017, right? And so since then, a lot of progress has been done. And if you look at one of the slides that I shared, the private sector engagement notification is now on the rise, significant rise across most of the high burden TB countries, because of this very strong push by by partners, international partners and local partners, national partners, to engage the private sector. Yeah.
Great. Questions? I don't see any online. Okay, is there one?
Yeah.
Oh, all right. Yeah, Amrita, please go ahead.
Thanks. I just wanted to applaud Charity. That was a great talk. Thank you so much. I'm kind of in awe with all the graphics and the visuals that you showed. And I especially like the Sankey chart, which I had not seen before. It's really flowing to show the patient flow. And I think you should have, I don't know, a data visualization course at Waterloo one of these days. But I think I was curious, if you're trying to convince, if you were to take this, I mean, you're already taking this work forward, but if you're trying to convince, partners such as local partners, in particular national TB programs, to invest in engaging these different sectors outside of the conventional health system. I mean, honestly, which of these charts would you pick? I'm curious. What would be your line?
Yeah, we've been asked this question, to be honest, a number of times. And the short answer is that I don't know. The reason why I say I don't know is that I have two top charts, which is the matrix and the Sankey, right? So each of them have their own advantages. If you have short pathways overall, and you don't have more than 5 or 6, use the Sankey. The Sankey is easier at some point to just see where they're flowing. So they went here and then they went there. Okay, this proportion is going here, this proportion is kind of easy to see that way. But it's not enough sometimes. So the matrix chart is still another one. So one recommendation I think we might end up making is that you can use the two depending on your purposes. But if you have very long pathways, more than 5, then you cannot even use the Sankey because it's too long. Then you have to go with the matrix chart. But the matrix chart is just beautiful for you to see at a glance where the majority of the patients are flowing into, what type of providers are they, and all that. Right. But what we found also, which is something that we are taking forward, in other fora, is that it's difficult to create these charts. When we do them ourselves, it's easily maybe a week or 2 to create one of those kind of charts, because there's no software that can do exactly the kind of chart that you're looking for. You can create Sankey with R, you can create it in Tableau, you cannot really create it with Excel, for example. So just finding the right software and then, arranging your data in a way that the software can even pick and create that chart for you has been an issue that we've discussed a lot in our team, and we're trying to see how can we make it simpler for countries, for program staff to quickly do this, right? Because when we presented this at the Union Conference, for example, there are some NTP staff that were coming to us and saying, how can we do this? We want to understand the difficulty our patients are going through. It's not enough for us to say they are delaying. We want to know where is the bottleneck, which type of providers should we intervene with? Should we go to traditional healers, or should we go to community pharmacists, or should we go to lab? Where are they finding the most difficulty, right? So they've come to us with these questions and we're reviewing it. And I think that's like the next step of our work, to try to figure out a simplified way for national programs to deploy this for their own communities and population.
Thank you so much, Charity. Thank you.
Yeah.
Okay, maybe just one last question. So actually I'm doing a scoping review with Amrita, looking at accountability for women in antenatal care being tested and treated for TB. And we're finding very few studies. And I think maybe it's because they fall under a general, a general theme of accountability in pregnancy care. But I don't know, do you have any thoughts? Like what do you look at that subgroup very much? And do you have anything to share about it?
So when you say accountability, it's more of the health system, right?
Yeah, it's more the onus on the health system, but yeah, that's right.
So to be honest, TB data sometimes focuses on issues I find like the qualitative data sometimes, for example, does not give us we've not done as much with, some of these cultural and contextual issues, for example, that could impact on, how women are finding, the antenatal care that you said for TB and all that, right? I find that sometimes it's lacking, but I'll probably need to see, like the abstract or something to think more creatively or deeply about, what other ways you can, maybe structure your search or whatever. But we've also run into this problem that sometimes we start with the question in literature review in TB, and we have to keep expanding because we can't find the right papers, and it's always difficult just trying to, maybe we should ask it in this way. For example, for this methodological review, we had to go back to the drawing board like twice. Right. We expanded beyond TB, and the result that I'm sharing here is not even just for TB. There are some pathway studies in cancer, in fever, febrile diseases, and all of that. Because sometimes when you want to focus on one issue, you won't find enough, so you have to sort of try to broaden.
Yeah, it's embedded in other kinds of studies.
Exactly.
And that's actually my suspicion is that's why we're not finding them, is because they're looking at maybe antenatal care overall, and if they don't indicate TB as one of the keywords, then it would just be missed.
Yeah.
So,
yeah. We found that a lot. I think 2 literature reviews that have been involved with, we had to just go back and just expand the topic to something that didn't even sound really like what we're looking for, just because we wanted to grab more types of papers that focused or even mentioned or said something about, a research question. But, I could maybe have another discussion.
Amrita just suggested let's email you and we can continue that dialogue if we're still struggling. Okay, thank you. So I guess that brings us to the end of our hour. So thank you so much, Charity, for enlightening us and sharing your terrific, wonderful research. And it's so great that someone is shining a light on this, so that the folks who need to be treated one day are.
Thank you. I appreciate it. Thank you for inviting me.